Great to see a lot of old friends. It's been really a fun morning, and I'm looking forward to chatting with more people. I'm excited to be back in your midst. I've been sort of off in another world for quite a few years, and I'm going to talk to you a little bit about that. I just wanted to remind you about something I read about recently, conflict of ego. And it's when a speaker presents information on an issue that only a limited number of surgeons have insight and share data that has not gone through a peer-reviewed process and probably never will. And the audience obviously is influenced by these thought leaders and lead to changes in practice which may be detrimental. And I would say that we're all suffer from this, and we have to be very, very careful with it. So I'm going to talk to you about skeletal dysplasia. There are many, many types. The vast majority of them, we understand their genetic causes, and very interesting. They're common. You're going to see them. And they're all different. They're all different. I could have had 20 or 30 pictures here, and they're all very unique. But you know what? They all have opportunities that are very, very similar to average stature people. Don't screw them up. They tend to be pretty complex deformities, and they're secondary to many factors, and I won't spend much time on this today. But the primary issue is abnormal epiphyseal and metaphyseal development. So on a genetic basis, and we see this one with achondroplasia, the other with metatropic dysplasia, well, look at the difference in that joint development. There are, of course, multiple other factors that lead to these complex deformities. The most important thing is to understand that they are multiplanar and multifocal. There's delayed and abnormal ossification, which impairs visualization and measurement. And deformity at one site will definitely influence deformity at other sites and impact on the treatment sequence. Remember, the spine is attached to the legs and vice versa, and when you realign one, it has an impact on the other. So, here's a little boy with pseudoachondroplasia, failed growth modulation. Has anyone ever seen failed growth modulation? I'm told by everyone it works every single time. Do you agree with that? No. But before you tackle this kid, before you do your osteotomies, what are you going to do? Well, you better look at his neck and back, right? He could have a spinal cord that is compromised, and when you lie him down for a few hours, he'll wake up paralyzed. So atlantoaxial instability is present in almost every single dysplasia we know. The exception is said to be achondroplasia. Well, I will show you that this is mostly true. When you look at these kids, be a doctor. Do a careful history and physical exam. If you've got a hypotonic baby with delayed motor milestones, figure out why. Is there a functional loss? Change in endurance. They could walk a mile last year, but only 4 blocks this year. Change in bowel bladder function. Could be as simple as just having to run to take a pee. And document it so that your associates and friends can figure it out if there's a change. So here's the standard flexion extension upper cervical spine x-ray. This is a child with SED tarda, 18 months old. Well, I challenge anyone in this room in that minimally ossified neck to make any comments about upper cervical or any other instability. You need to go to a FlexX MRI. And I already missed the boat on this kid. 18 months old, already has instability, cord compression, and myelomalacia. This is what we want to avoid. Cervical stenosis can be there for many reasons. You could be born with it. RCDP is rhizomelic chondrodysplasia punctata, very interesting disorder with severe rhizomelia. Looks like the elbow is attached to the shoulder. Instability, of course, causes stenosis. And then sometimes, if the space is taken up by something else, then that can be very significant. We see that with the MPS, and you see that at the end of the arrow, the thickening behind the odontoid. Here's a child, came to me for evaluation of her hips. She was MPS 1. She received a marrow transplant soon after birth, and had been managed at a world-famous institution. Came to me to ask about her hips. I said, well, what about your neck? Is anyone following your neck? Oh, yeah, they look at my neck every year. So this is what I saw on a single two plane x-rays. And look what I saw on a Flex X MRI. So just because an institution is really experienced in some areas, they may not be in others. So this child went on to a C1 decompression and a standard Harms technique, which most of you, I'm sure, is Greek to you, but not to me. But you know what? So just because they had a successful previous fusion doesn't mean they're going to be okay. We looked at our group of Morchio and SED, and we found a high incidence of instability developing under an established fusion. So look for it. And here's how we had to treat that child. So, coxivara, very common in spondyloepiphyseal dysplasia and other disorders. Here you see somewhat the natural history. The 5 and 12-year-old are the same child. The 27-year-old is not, but it's similar story. We think we can change the natural history here. We haven't proven it yet, but we're close. But here's the index case that led me to give you this talk today. So this child came to me from the Bay Area, actually, lived up the street from Kevin, actually. And he had a severe kyphoscoliosis with a lumbar lordosis, and exactly how he stands is what you see on that x-ray. His neurological exam was completely normal. He was ambulatory. He had restrictive lung disease and myopia, which is typical. I did a pull film and tried to figure out what I was going to tackle first. Well, I chose the hips. And you all think, well, what an idiot. Well, I chose the hips because I wanted a stable lumbar spine to build the rest of the spine deformity on. Because we know that extension osteotomies in these kids, combined with derotation, correct the retroversion, correct the flexion contracture, and correct the coronal deformity, will result in a good hip and a straighter lumbar spine. So, went very unremarkably, 3 hours, not too much blood loss. In the PACU, he couldn't move, but had sensation. Anterior cord syndrome. Why? Well, he had a really significant upper thoracic kyphosis at about the T5-6 level, and we assume had a vascular injury at that level. Here he is, and there's the point about straightening out the lumbar spine. You can do a lot by hip osteotomies. He went on to traction, anterior release, vectors, and then finally a final fusion, and he's in college in this area doing extremely well. So I was really lucky. Clayne White in Seattle wasn't so lucky. He had a child with MPS 1, Hurler, and he had complete paraplegia, which did not recover. Identical procedure, except he did acetabular osteotomies at the same time for a different problem. So this led us to talk about it. We looked at other institutions. This has happened all over the world. I can't tell you how many cases I've heard of. Very hard to get them because most people won't talk about them because of medical legal issues. But we reported these two, and we decided in our institutions that we are going to very carefully evaluate these children with kyphosis preoperatively and monitor them for any procedure lasting more than an hour. It's interesting, the literature, very little on this. The reported incidence of neurological injury is less than 1%, And there are numerous reports of neuromonitory abnormalities in the prone positioning, but interestingly, all ours were supine, and most of the ones we've heard about are supine. And sagittal deformity is clearly an issue. So, here's another patient, came up a little bit later. What did I learn from the last case? Well, he was MPS 6, 5-year-old bright boy with meritolami, a little bit uncommon. Bilateral hip dysplasia that was causing him more problems. Came to me for reconstruction. So we chatted with him and found that he had no neurological complaints and normal neurological exam, standard workup, very typical hip deformity with acetabular and femoral deficiency. He had a flexion extension x-ray, which was stable of his spine. The MRI was completely normal. A little bit of thickening. Notice that thickening behind the odontoid. And he had this mild thoracolumbar kyphosis. I wasn't concerned about that at all, but I monitored him because of that. So, day of surgery, we set up the sterile leads, and I'll show you those in a second. And we did bilateral approaches. I had a fellow with me. We were well into this. We had our pins in when suddenly my neuromonitoring guy, who is a PhD neurophysiologist, says, Will, I have not got MEPs in the lower. I got them in the upper, and I've been troubled with this since you first put them in this position. I assumed it was a technical problem. So here's the imaging, and you can see here basically no motor evoked potentials in the tibant and the abductor lucis. Here's what normal looks like in the green, and this is our patient. So we stopped, we put in psoas and upper rectus leads, which were low amplitude but were within normal limits. Upper extremity remained normal. Absolutely, this child had something going on. We closed him, we flipped him to a lateral decubitus position, used the standard protocols that we use for spine, increasing the MAPs, temperature. We did not give him steroids. And we did a wake up then. He was moving his feet, weak but intact. So we took him for an MRI. There was really no issues on the MRI other than the kyphosis and mild impression on the conus. And we assumed there's transient ischemia. But I can tell you my neurosurgeon buddy did not think that. I did. He recovered. He got a little bit better over a few days. He walked about a week after surgery, but was quite weak. So I convinced the neurosurgeon we had to go to the spine. So we brought him back 10 days, 12 days post-op, and look at his signals. They're still very abnormal. And these attenuated signals prove in the neuromonitoring literature there was an injury to that spinal cord. So, waited 3 months, brought him back, absolutely normal signals, as you can see in the green there. And so I did a decompression, instrumentation, fusion, realigned him. It went uneventfully, completely healed, normal potentials, came back a few months later, and I did his hips, again, normal potentials. So if I didn't have neuromonitoring on that child, I probably would have been dealing with a paraplegia. And this can happen to anybody in this room. Spinal stenosis and achondroplasia, obviously a much more common issue. It can be present all the way from the head to the butt. We all know the symptoms: decreased endurance, fatigue, neurogenic claudication, numbness and tingling. Little kids say weird stuff. My legs feel dead. I feel bugs crawling, spiders. Bowel and bladder issues are often very subtle. 25% symptomatic by 15, 80% by the 6th decade. So every single one of the patients you lengthen for stature have potentially this problem. So cervical medullary compression occurs usually in infants. It's usually not a problem in later life. Affects about 60%. Only about 20% need decompression, and it can cause everything from developmental delay to sudden death in a PICU. Here's the problem I was talking about earlier. Cervical instability, pathological surgical instability in achondroplasia does not typically occur. But if you've got a narrow foramen magnum and C1 area, if you have physiological instability, that can cause cord compression. This has not been written about. We talk about it in my world, but be careful, it can occur. Spinal stenosis occurs elsewhere in achondroplasia for all the problems you know. Vertebral bodies are shortened, the pedicles are short and thick, the intervertebral discs are wide, ligamentum flavum gets thickened as well do the facets with age, and a gradual decrease in the canal volume. We evaluate it pre-op with an MRI. We don't do myelograms anymore. Maybe there's the odd instance. But we don't do MRIs to determine if there's spinal stenosis. You determine if there's symptomatic spinal stenosis by a history and physical exam. So the treatment, in a child is maybe weight loss and exercises, and an adult, probably decompression. And decompression is not simple. There's a lot of problems. You think, oh, dural tear, that's no big deal. It's a big deal because it's a very thin, papery dura that can rip around the front. In young children, you have to instrument them because releasing those posterior tethers will result in a kyphosis almost every time. So here we see multiple level of patient of mine, complaints of upper and lower extremity, and I had to do a neck and thoracolumbar decompression infusion. So it's not that it just happens down low. So this comes to why we're here. Genuvarum. Everyone in this room, I'm sure, has corrected genuvarum in a child with achondroplasia. Very common, not always progressive, not always symptomatic, and osteoarthritis in the knee is actually very rare in this population. So here's a patient. You're going to do realignment. You're going to fix it all. And my choice is circular frame, but you may have other techniques. But what are you going to do with this patient? You're going to look at them really carefully for any symptoms and signs of spinal stenosis. You're going to determine if they have a subtle kyphosis. And you're going to be really careful about managing this patient. So what do? I monitor them. And I don't monitor them all. I monitor the ones that I'm concerned about. And so these are the leads. It's not so bad. You can see I just actually did this patient about a week or two ago. And, two-level frame. And you can work around it with the leads. Just sterile leads go off. And it's relatively easy to do. It's a bit of a fuss at first, but you quickly get used to it. So here was this child. No issues, healed up. This was not the same child, obviously, but all healed up and did well. Another population, MPS, I'm going to focus on Morquio syndrome. So we know there's a very, very high incidence of atlantoaxial instability and upper cervical cord compression, and a high incidence of neurologic compromise. Very, very common. Thoracolumbar kyphosis seen in these kids, natural history is completely lacking. We know neurological compromise can occur from it. And the problem is the MRI really underestimates the deformity and compression. Here's an example of a 13-year-old MPS II that had a severe kyphosis and went on to a VCR I did and decompression infusion. So they can be managed and managed safely, successfully. But back to our world, someone with Morkiel syndrome, hip dysplasia, genu valgum, and ankle valgus. Every single one of them have it, whether they've been treated with enzyme or not. So I would advise you carefully look at these people and you monitor them. There are many, many examples that I'm aware of paralysis and death after attempts at hip and knee reconstruction in Morkiel. There are other problems with Morkiel, which I'll get to in a second. This is an interesting case that might get you a little upset. So polyostotic fibrous dysplasia, McCune-Albright syndrome. We all know the issues with it. Here's a child I took care of. He presented to me many, many years ago with these deformities from recurrent fracture. He got realigned. I worked my way through all the limbs, through all bones at his lower extremity. He developed, when he was around 7 or 8, some discomfort. He had a thoracic kyphosis with a thoracolumbar curve, a moderate cord compression, and was starting to develop neurologic problems, and it was progressing. Look at the quality of his bone. So I had an answer for that. So I had a planned VCR, couldn't do it because we lost the signals. So I realigned him and did a decompression as best as I could, instrumented him. So of course, he got infected, fell apart, and I had to take the thing out. So we basically abandoned his spine. He was stable with it. His neurological function was satisfactory. He was ambulatory. But he started to go south in terms of his lower extremity. So he was developing recurrent deformity in both lower extremities, the right femur being worse than the left. I was relatively busy when this happened just recently, and one of my associates took him over and was planning to revise the right femur, do an osteotomy and revise the fixation. He ordered an MRI. Unbeknownst to me, and I get a call in the middle of the night, a couple of calls after it all started, from the father who said, "My son can't feel his legs and can't move them and can't go to the bathroom. What's wrong? He's been like this ever since the MRI finished." He was at home. He had taken this boy home, probably paraplegic at that point. So we rushed him back, and I did an emergent decompression and anterior fusion. There's no use putting anything in the back. And he's completely normal. It was magical. One of the coolest things I think I've ever done. But what did we learn there? When you send your patient, your child, to MRI, and a radiologist and an anesthesiologist and an anesthetic sedation team puts your patient to sleep, intubates him, and then this kid did cardiac MRI, 3 hours of general anesthetic on his back with a 100-degree kyphosis. That's what happened. So we can't monitor. We've actually looked at that. We thought it would be kind of cool. So we talked about limiting the time under non-monitored anesthetic, position modifications, doing it on a lateral decubitus position. But this is a big, big problem. So you cannot anesthetize these people for long periods of time when you're assessing them. So you have to be aware about that as well. He luckily recovered from the fusion, and Mihir went on and did this realignment for me. So joint arthroplasty. I used to be a children's doctor, and the last hip I'd done was as a resident. But now I'm a young adult person. I do up to 35. And so I'm seeing like one person after another who wants a joint. The problem in this group is that there are Amazing challenges: articular, periarticular deformity, capsule, soft tissue abnormalities, contracture, poor bone quality, narrow intermedullary canals. About 20%, we've done about 20 so far, about 25% of these require custom components. As you know, getting custom components is not so easy anymore. There's quite a high complication rate reported in the literature, but it's a very, very limited literature. And we're doing them young. I actually didn't do this one, but this was a 12-year-old girl with sticklers. Remarkable result. But these kids have significant spine and other problems. Here's a Morchio syndrome. Got to me after the hips are long gone. I did some realignment to fix some genivalgum, but you can see severe hip problems, severe hip pain. And here was a custom component. Pretty good result. Most of these kids will need acetabular augmentation. And you can see those custom components fit pretty well, but you get splits all the time, hence the cables. But more importantly, here is the monitoring. And you can see in the blue column to your right when signals disappear. Some of that can be due to spinal, and some of it can be due to positioning and stretching of the sciatic nerve as you bring these legs into the position for the total hip. And remember, we're doing a lot of lengthening in these kids as well, so you have to watch this extremely closely. So there are many other medical problems. Hydrocephalus and achondroplasia, you have to monitor the head circumference. If there isn't someone monitoring these children who understands it, it might fall to you to keep track of this. Cataracts and morchios, retinal detachment. Well, you go, why does retinal detachment happen in type 2 collagenopathies? Because type 2 collagen anchors the vitreous retina. And I've seen blind people with Nice syndrome. Recurrent otitis media, which will cause deafness. Hearing loss, which is sensory neural in Nice, as you see there. Cardiac, kids with Ellis-Creveld who come to you with an extra finger or an extra toe, post-axial polydactyly. Most of those babies have congenital cardiac defects, and 40 to 50% need surgery. Respiratory, well, if your cartilage is bad, the cartilage around your trachea and bronchus is bad as well. And so it's floppy cartilage. Think of your vacuum hose without the metal support for the hose. How's it going to work? So these kids are very, very difficult early in life. Sometimes they use trachs, but you can decannulate them later in life. Apnea, compression of the brainstem in achondroplasia. Restrictive lung disease. There are many disorders. Here you see a 30-year-old who I've treated for years who has veptors with severe respiratory compromise. She's trach and vent dependent, but has managed to do pretty well. Compressed tracheas, as you'll see in a second. And then immunological problems, McCusick's. That beautiful little girl I took a picture of many years ago is dead now. And those marks you see on her leg are recurrent fungal infections from her T-cell abnormality and from her RMRP gene abnormality. Here's a boy I just took care of who had very severe varus, realigned his femurs, then just realigning his tibias and finishing off right now. Multiple recurrent pin tract infections because of the underlying T-cell abnormalities. These people, we just did there's not much work in this area, but we just did a questionnaire, and high incidence of depression and pain in these individuals. You have to be very careful about narcotic use. I had a girl present to me from a major institution. She was Nice syndrome, about 9 years old, and she had narcotic patches because of her hip pain. All she needed was a hip realignment. and the management was narcotic patches. We have to be very, very careful about the, in the pain world, there's some pretty odd therapy out there. Children and young adults with dysplasias have significant anesthetic risk, mostly to do with airway management. I got this email a couple of days ago, reached out to me. I don't know, I saw this girl many, many years ago at some convention, and they're in the midst of a sequential spine procedure, and they couldn't intubate her. And she was desperate about this. Our anesthesia people reached out, helped them, and the girl is now intubated, supposedly after several weeks of trying to figure out what to do, not several weeks, a week. Another phone call I received was an old friend of mine with SED. At 29 years of age, she was in a city and needed a breast reduction. She met a plastic surgeon who told her, no problem, I can do that for you. I work out of a clinic. And she said, well, Dr. Mackenzie says my neck's really stiff and I'm difficult to intubate. Oh, baby, my anesthesiologist can put a tube into anything. Well, guess what? That girl who was finishing her PhD in psychology died because he couldn't get the tube in that day. And this happens. So there is some literature. I belong to a group called the Skeletal Dysplasia Management Consortium. We write articles every year. We do a sort of a Delphi thing. And we did one on perioperative management, which is useful, and you might want to have a look at that. Anesthetic complications in MPS are amazing. I'm not going to read through them a lot. One thing that's kind of interesting, did you know that epidurals in MPS, particular Morchio, has been associated with paralysis, cord injury? Relatively common, actually. So, you brought your child with Morchio to the operating room, and this is what the trachea looks like. It turns right at the thoracic inlet. The innominate artery lies in front of it. And how's your anesthesiologist going to get a tube into that person? So what happens if they don't know this and they give them a long-term blocker, neuromuscular blocker, and they can't ventilate with a bag? Certainly can't trach them. That's not going to help. So we've studied a lot of it. We follow about 70 Morchios. We've noticed progressive deformity of the trachea in Morchio syndrome. That is what a trachea looks like in a child that we just had to resect that tracheal segment. Our cardiac group has experienced in about 10 of these. This is that same child, and you can see how the innominate on that CTA lies right in front of the trachea, deforming it, and then you see the shape of the trachea in that blue. Metatropic dysplasia, very, very stiff necks. I fused a lot of the upper cervical spines of metatropic dysplasia, and in kids we get spillover to adjacent segments. You can get fusions extending down the cervical spine. This happens a lot in Morchio. And you can see, in our experience, a large percent of these kids have problems getting good airway management with anesthesia. And here's why. When I started, the anesthesiologists were all doing fiber optic intubation. And I would say it's a very rare event for me to see that now. They're all using glide scopes. They say it works better in this population. Interesting problem, primordial dysplasia. Majewski osteodysplastic primordial dysplasia, type 2. These kids are less than 3 feet tall. They got pretty good brains, a little bit of cocktail chattery stuff. That reflex hammer is the length of a 5-year-old, that girl's 5 years old's chest. So here we see a child, different one, 14 years old, 3'3", 28 pounds, 25 centimeter thorax, and an endotracheal tube that is 4.5 millimeters. Well, you better be prepared to manage that patient post-op. I thought you might be interested. This is a pericentrin problem. Pericentrin is that thing that you learned about in biology that anchors the chromosomes to the polar regions with cell division. And you can see there's the wild type, that's normal, cell division, and then the knockout. And look at the disrupted. And so these kids have very, very primary problems in actually cell division and cell formation. They also have really interesting problems. We wrote an article on basically it's like a slip. We call it coxivara, but it's really a dynamic slip that occurs in very, very young children, 1 to 2 years of age. I put screws into some of them. But the important thing is moyamoya disease. Probably never heard of that. Well, moyamoya disease is a progressive obliteration of your cerebral vessels, and they also have aneurysms. And these kids die from this. And when you give them an anesthetic without understanding this, you can cause further cerebral infarction. So you got to be careful when you do operations like this or when I do osteotomies to fix their hips. Schwartz-Jampel. Probably a lot of you have seen this. These are these kids with bad club feet, with sort of pursed lips. Guess what? They have an increased incidence of malignant hyperthermia. I guess it's close to the ranitidine receptor. So I hope this potpourri has sort of been helpful and maybe alerted you to some things that maybe you've been lucky to this point avoiding. I just want to make this clear that this is not just Will working in isolation. I work very closely with a large group, both in my hospital and outside. You can see it's a large multidisciplinary group, a large group we work with. This is a small part of the people I work with. But I tell you, my focus, my entire focus is on optimizing function, correct the deformity to reduce pain and prevent future limitations. Don't just correct it because it's there. So, back to the old orthopedic principles. Carefully evaluate what you're doing. Think about the effect on adjacent levels. Execute it properly. And think about all those things that can happen related to organ systems outside of what your expertise is in. So this is where I come from. This is, most of you know this, but our hospital is built on the estate of Alfred I. DuPont, built in about 1900. 1900, he spent $10 million on this estate. Could you imagine the value of that in today's world? Our hospital was called the DuPont Institute. It was built in 1940 and evolved from primarily an cold orthopedic institute to a multidisciplinary children's hospital that it is today. This was back sort of that building was built in 1980. The Carillon is where A.I. DuPont, his third wife, and his dogs and his brother-in-law are buried. And you say, why the brother-in-law? Well, the brother-in-law took the $35 million that he left in his estate in 1935 to $7.5 billion today. This is an extension that we put in maybe 4 or 5 years ago, in the opening of it. But this was a tremendous honor for me to speak to old friends and some new. It's a great organization. I'm really excited to see how it's evolved. I'm sorry I haven't been here more. I'll keep in touch. Thank you very much.